Um, well, thank you, and appreciate the opportunity to be here. My task today was to talk to you a little bit about CAR T-cell therapies, which I think really are going to revolutionize cancer care and have a significant impact on disabilities. This is my disclosure information. Now, when we think about cancer cells, it's been clear for many years that cancer cells have these well-characterized surface proteins, a fingerprint, if you will. And these proteins can be targeted to kill the cancer cell with various modalities, things like monoclonal antibodies, engineered antibodies, immune T cells, and what I'm going to show you is targeting them with genetically engineered T cells, in fact. Most of what I'll tell you about today is targeting a protein on the surface of a cancer cell called CD19. We can target truly any one of these proteins that might be specific to the malignancy. But just about all B-cell malignancies express CD19, making it an almost ideal tumor target. And we target them with something called chimeric antigen receptor modified T cells. This is just to remind you what the terminology means. Remember that the chimera was this mythical, this beast from Greek mythology made up of different parts. It had the tail of a serpent, the body of a goat, the head of a lion. Well, a chimeric antigen receptor is something made up of different parts. It has an antibody on the outside that targets the specific protein on the cancer cell. It has these sequences in the middle that keep the protein stably expressed on the surface of the T cell, the immune cell. And then inside, it's got signals to activate the T cell, telling the cell to grow and to kill its target, as well as to survive for long periods of time. And this is how they work. If you understand this slide, you will understand CAR-modified T cells or chimeric antigen receptor T cells. We use gene transfer technology, similar to what Dr. Tisdale just explained. A lentiviral or an HIV-like virus brings in new genetic material that tells the T cell to express this CAR protein. That gives it novel specificity where it can now recognize CD19. So what you see here is this virus particle bringing in a new gene. It gets stably integrated. It directs expression of this new protein that gets transported and integrated into the cell surface, now allowing it to see CD19 on the cancer cell when it couldn't before, hopefully leaving behind a dead tumor cell. And that's how this technology works. So why all the excitement? I think the short answer is because it works. And when it works, it can work dramatically. It's been tested in most B-cell malignancies at this point. And it's been tested in patients who have almost no probability of achieving remission and just about no probability of cure. You can see in this right-hand panel, in diseases like ALL, 80 to 90% of these patients achieve a complete remission. 50 to 60% are leukemia-free 6 to 12 months later. And in other diseases like lymphoma, CLL, myeloma, anywhere between 50 to 100% of patients respond. A third to up to 70% of patients have these ongoing long-term responses. When it works, it has been quite dramatic. And the way it works is shown here. A patient comes into the office. Everything in blue on the top happens in the patient, in the yellow it happens in the lab. He undergoes leukapheresis to have his T cells collected. They get brought to the lab where they're exposed to this virus that has the new genetic material. The virus infects the cell, it brings in the new gene, the cells are gene modified, and then over here they're grown in the laboratory over a period of about 7 to 14 days. Once they're grown, and there are a sufficient number of T cells, the genetically modified T cells are isolated. The patient comes into the office, they receive fairly standard chemotherapy designed to weaken their immune system so that they can accept the new T cells, and those T cells can grow in the body, and then they get their T cell infusion. In fact, this can happen either as an inpatient or it's safe enough in many circumstances. We do this whole thing as an outpatient. Now, one of the first applications of this therapy was to patients with ALL, acute lymphoblastic leukemia. When patients have relapsed or refractory ALL, their prognosis is dismal. About the median survival is less than a year. Their 3-year survival is less than 25%. Allogeneic transplant has been the only cure for really relapsed ALL, but for patients with refractory disease, it's largely ineffective to the point that we rarely offer it. So there has been this desperate need to have better therapies. So these CAR T cells were applied to patients with relapsed refractory ALL. These were kids and young adults. And this was really the pivotal trial where all the excitement was in part generated. Remember, these are patients who are likely to die of their disease within a few weeks without effective therapy. And you can see that of the 75 patients treated, 81% achieved a complete remission. This was by minimal residual disease testing. You can see their overall survival and their event-free survival was over 50% out beyond a year. And the vast majority of relapses happened at a year or by a year. And in fact, patients were very unlikely to relapse beyond that time. Most of these patients who are in remission at a year do not subsequently relapse and in fact might indeed be cured. And it was this trial that led to FDA approval of what was then called CTL-019, was then licensed to Novartis as the drug Tisagen-Lec-Lucel, or Chimera, and FDA approved in August 2017, just 7 years after the very first patient was treated with these cells. To give you some sense of impact of CAR T cells, I told you that the prognosis of patients with relapsed or refractory ALL is dismal. You can see an event-free survival curve here on the left, showing you that once a patient relapses with ALL, the likelihood of being alive 2, 3, 4 years later is really quite low at about 10%. And this is the curve I just showed you, where over half these patients have event-free survival beyond that first year. I'll just show you that really dramatic difference from CAR T cells. There are now 5 FDA-approved CAR T-cell products for 5 different indications, all in B-cell malignancies. The majority of the B-cell malignancies, perhaps with the exception of CLL, but ALL, non-Hodgkin's lymphoma, mantle cell lymphoma, and even multiple myeloma, where there's a recent product approved and potentially a second one in the near future. Of course, like with many of our therapies, when we choose a CAR T-cell, which product and where we treat patients, a lot of it has to do with the toxicity, and there are some very unique toxicities. The major unique toxicities of CAR T cells is something called cytokine release syndrome. These cytokines are these inflammatory molecules released when you get immune cell activation. Think of it like having a very, very severe flu, only potentially even worse. It is mediated by something, a protein, an inflammatory molecule called interleukin-6. There is an anti-interleukin-6 antibody called tocilizumab. And so the cytokine release syndrome can actually be managed quite effectively in most patients by administering this drug tocilizumab. Another unique toxicity is a very unusual neurologic side effect where patients have trouble speaking, they become confused, they can become tremulous, have seizures, and even become comatose, and that tends to be managed with steroids. The remarkable thing, though, is that almost all patients recover their toxicities by day 30. Treatment-related mortality has been reported in the low single-digit range and up to really 0% in many studies. Many of these patients develop hypogammaglobulinemia. This therapy kills their normal B cells, which produce antibodies. So one of the long-term toxicities is the inability to make antibodies over time. The cytokine release syndrome can really involve almost any system in the body. I'm not going to go through this for the sake of time, but it really can be quite severe, but again, can be quite manageable. This is just showing you the fever curve of one of these patients. You can see they were having a cytokine release syndrome with fevers as high as 105.4, coming and going. At this point, the patient was becoming hemodynamically unstable and received this drug tocilizumab. And look at that, the fever just within a couple hours dissipates. They were needing oxygen. They no longer needed oxygen. Their blood pressure was dangerously low, and that resolved. This can be safe enough that we treat the majority of our patients as an outpatient. You can see 2/3 of our patients receiving Lete-Blue-cell, are treated completely as an outpatient. About a third ultimately get admitted to the hospital, about 14% within 3 days, and another 18% within that first 30-day period. Well, since the goal of this session was to discuss emerging stem cell treatment technologies and post-treatment management that will potentially lead to improved outcomes, hopefully I've made the case that indeed these CAR T cells do result in improved outcomes compared to what we have. And so with that, I'd like to just end with perhaps a more provocative question, and maybe a bolder question, and ask, what are we doing in the long term? Are we really curing these patients with leukemia and lymphoma? Well, I showed you that many of these patients achieve a complete remission and have really no minimal residual disease detectable, very, very little disease left. The majority of recurrences happen in that first 6 to 12 months, but I started to tell you that many of these patients are alive and well, not just beyond 12 months, but we have patients at 10 years, at 8 years with ALL, at 7 years with lymphoma. We still tend to hedge, and people tend to be very careful and say things like CAR T cells may be curing some of these patients with ALL or CLL or lymphoma. I think with this therapy and these data, we don't have to hedge so much. Maybe we could say probably curing some of these patients. Should we say likely curing? I actually think with these kind of results, it's time that we can say these CAR T cells are indeed curing some of these patients who previously had incurable, rapidly progressive, and life-threatening malignancies. So with that, I will turn mine over to Dr. Steve Devine and be back for the discussion session.